ones I created a while ago. They need to be updated a little, but it'll get my point across. So this is basically beginners. I call it VTE 101. So VTE, this is a worldwide disease. You can see some of the demographics here. And it should be noted, I'm talking about DVT and not pulmonary embolism, even though they're basically one and the same. Silent PE develops in a large number of patients with DVT that's untreated. Okay, so let's go over to the importance. About 900,000 VTE per year in the U.S., 60 to 100,000 PE deaths a year. VTE is DVT plus PE. 50% of DVT patients have long-term complications. That's called post-thrombotic syndrome. I'm not sure if you guys are aware of that. We'll talk about that in a little while. And if untreated, not on extended anticoagulation, about a third of patients will recurrence over 10 years. And a subset of PE patients, although not great, but not insignificant, will develop something called thromboembolic pulmonary hypertension. Okay, let's examine this problem. Say there's 80,000 deaths per year of PE in the U.S. That's 240 deaths a day, 10 deaths an hour, 1 death every 6 minutes, and 1 person in the world dies every 30 seconds. This is a big thing. People don't break it down into this, but this is really a serious problem. It's the third most common cardiovascular disease after MI and stroke. The thing is, people in the community know about MI and stroke. Not so much pulmonary embolism. You know, if they've had one, yeah, they know about it. If a family member or a friend had one, they know about it, but in general, not as much. And this is an old slide, more deaths than AIDS, breast cancer, and MVAs combined. These are things people know about. Now it's unusual to die from HIV-related disease unless, you know, you're not taking your treatment. Breast cancer is a serious problem. You know, most women with this and also don't die from it. Some can, but they have good treatments. Motor vehicle accidents, obviously, they're horrible, but it causes more deaths than all of them combined. It's a number of hospital deaths. DVT, PE are two spectrums of the same disease. And the other thing, half of these people, and this stat is somewhat old, were recently hospitalized in the last 3 months. I've been talking about this a long time. And really, not 20, but over 15 years ago, there was a real push for prophylaxis in these patients, medical patients, and surgical patients when they're hospitalized. But the idea is to prevent problems down the line. So I don't know if this still stands true. And you guys write in your admissions orders, if you're doing that, you know, for most of your medicine patients, these patients are going to be prophylaxed. Okay, definitions. This is very important. So, approximal, let me just draw a picture here. Here's a lake. This is the iliac vein, common iliac vein, external iliac, okay, which becomes the common femoral vein, which becomes what used to be the superficial femoral vein. Now it's called the femoral vein, popliteal vein. And then you have the trifurcation. And popliteal vein in the above is considered proximal DVT. Distal DVT is below that peroneal vein, posterior tibial vein. For some reason, we don't see clots in the anterior tibial vein. Okay, so proximal DVT, if you don't treat it, that's the chance of developing a PE. The higher up you are, the greater the chance. So if this is in the iliac vein, 50% chance. Popliteal vein, probably 25% chance. Distal DVT, you have a 20 to 30% chance of becoming proximal. So, not quite as serious, but usually they're treated. If not, you need to monitor them for propagation.
Is distal more common, or are they equal?
No, they're not more common. And this is all tricky because, and this has changed a lot through the years. Now most patients with pulmonary emboli, if you make that diagnosis, you're going to scan their veins and you can look for proximal DVT. The reason why you're going to do that is to give you a prediction of what could happen in the future. Back in 1990, which I'm probably like that's when but there was some literature that if somebody did not have proximal DVT, even though they had pulmonary embolism, it's not massive or some massive, they need to be in the right place. That's not the case, right? You need to be aware of these definitions. Let's move on. Okay, now here are the problems. PE, post-thrombotic syndrome. With the DVT, that's not PE. Post-thrombotic syndrome is you have clot, doesn't all dissolve. You have destruction of venous valves, you have venous hypertension. And people could be left with chronic leg swelling. If it gets worse, it could hurt when they walk, it's called venous claudication. And if it really is severe, you could get ulcers. And if you have a young patient who develops this could be a lifelong, a lot of disability. Acute DVT, 2/3, first episode, 1/3 recurrence. Okay, proximal DVT, you have more problems. Okay, most PEs come from the legs. There's some exceptions. There's pelvic vein thrombosis, renal vein thrombosis, upper extremity thrombosis, and clot in the RV due to a primary problem with the right ventricle. Of these upper extremity thrombosis, you're going to see these, patients with pig lines, with catheters, and sometimes with pacemakers. But most clots come on the legs, just not all. Okay, so how do you make the diagnosis? This was a new concept. Time has flown for me, so this is really not a new concept. But this is important for anything you do in medicine or any field where you have to make a diagnosis. You look at pretest probability here. So, someone comes in and they have leg pain. What's the likelihood they have a DVT? Okay, so look at these things over here. Active cancer, immobilization, a cast, a unilateral swollen leg, pedic edema, the affected leg, paralysis, leg tenderness, calf swelling, dilated veins. Look at these things. So where this is important, you have different scenarios. Someone could show up in the office with pain in the leg. Was everyone in pain in the leg? Do they have a DVT? And if they have a DVT, theoretically, that's an emergency. You can deal with it right away. Okay? Now, if you have somebody with known cancer who comes in with a unilateral swollen leg, okay, that's an emergency. That's an emergency. We had a situation in my office last week, and my student Scott could attest to this, where a lady came in, history of ovarian cancer, had a unilateral swollen leg, and this leg was swollen. And unfortunately, it took so long, I got a stat duplex ultrasound on her, and she came back to the office, almost when the office was closing, you could have had a disaster. So they're all things, you could have a young person, you could be running around the track and, sprain, and you pulled the muscle. That's not an emergency, but then people come in with all this stuff and you have to be able to sort it out. But this is the idea that this for pulmonary embolism and for anything, and before you order any test, you guys got to think, what's the likelihood they have this condition before you order an array test? Okay, so how could you make the diagnosis? One thing is the D-dimer, which is a great weapons. So it's used often for PE, so you can rule it out. This, if it's positive, it doesn't mean they have a DVT or pulmonary embolism. If it's negative, it's helpful. So if a patient comes to the emergency with a swollen leg, they could get that. There's a problem if they come to the office and you're worried about that. You're gonna send them down for a D-dimer, you're gonna have to wait for it to come back. And that always, we can't do that. I mean, theoretically, that's the way you should go if you don't want a strong probability. If you really feel this is a DVT, go straight to the ultrasound. D-dimer is not real helpful in a hospitalized patient. What happened here? Okay, there we go. So the way you make the diagnosis is a Dublin's compression ultrasound. And that ultrasonographer will basically take the transducer and put it over the vein. And if you can't compress the vein, that's a clot. You may or may not see a clot, but the lack of visualizing a clot does not mean that it's not DVT. But the lack of compressibility, that's how you make your diagnosis. And this is an easy test to do. To diagnose PE, you need a CT, and with that, you're giving the patient a lot of radiation. It's a more complicated test. This is not as good for a distal DVT, although we can diagnose them. Okay, moving on. Okay, now what about differential diagnosis? What year are you guys? Just fourth?
It's like fourth and third.
Okay, so you're what year?
Third.
3,
4.
4, 3, 4. Okay, so this is the core of internal medicine. Somebody has symptoms, signs, think what it could be, make a list of things, and then you work your way through it. And clearly, the most common thing of differential is cellulitis. And how do you determine that? So, you see someone with a red swollen leg, what do you do? So there's some clues. If they're erythematous, and DVT always is an erythematous, you can look for skip areas of erythema, where it's red, but it's not confluent. Number 2, cellulitis most commonly is caused by strep, and you see a fire engine red. It's a fire engine red, okay? And if somebody has cellulitis, most likely it's caused by athlete's foot. You actually look between the toes and you see cracks in the skin, and that helps give you a diagnosis. The other thing is a ruptured Baker's cyst, which often goes away on its own. Sometimes it needs to be trained. That's called pseudothrombophlebitis because it looks the same way. It looks the same way. That's the differential. Ruptured medial head of the gastric nameless muscle, very rare. Etiology, okay, you guys have all seen this before. So stasis, these are the things. So now, and for a long time, I mean, time has really blown through me, but to be admitted to the hospital, you need to be sick. So, most of the medical patients, look at those diagnoses I have there, they're all sick people. Surgery, there's certain surgeries that are high risk, ortho surgery, cancer surgery, hypercoagulability. I'm not gonna spend a lot of time on this because this has changed a lot. We often don't do these thrombophilic or hypercoagulable tests on patients because we're treating them long-term anyway. Factor V and the prothrombin gene mutation are the most common causes of inherited thrombophilia. Antiphospholipid antibody syndrome, if you suspect that, you have to diagnose it, you have to attempt to diagnose it because they need to be treated with warfarin. Malignancy is something you have to think about. You pan scan everyone with VTE mode. When you do a good history and physical, they recommend routine cancer screenings, breast, PSA, colonoscopy, but the cancers that really have the strongest association with VTE, pancreas and stomach, and these they don't recommend routine screening. Estrogen. So if a woman's on the pill, postmenopausal estrogen, yes, pregnancy. Okay, and risk factors are more implicated. So often if a woman's on the pill, and she has a clot, she may have factor V blood or something else driving this also. Who do you test? This is an old slide. This is gotta go. Normally, see, we're treating these people longer term. And the interesting thing about thrombophilia, see factor V blood, you guys all learned about that medical school. So say you have two patients with factor V blood, these two people, okay? You have it and you don't, you will have a higher likelihood of initial DVT, but you won't, chances are you'll never have a clot. I like a 5 to 6% chance of having it. But you don't have a higher incidence of recurrence. So if you guys both have clots and you have factor V blood, it's not like I'd be treating you longer than your colleague over there. And with that, we're not getting this as much. When I ask about a family history, sure, obviously somebody has a DVT at a young age, and we're concerned with that. Woman with recurrent pregnancy loss, you need to check the vein possibility. This is changing because we're extending coagulation. And if it's not going to change what you're going to do, then you don't have to get certain things. Okay, treatment. Now this has really changed. I really need to redo these slides. So back in the day, we gave IV heparin, and around 1996, hopefully we switched to Lovenox. Fondaparinux is actually a good medicine. It came around 1999, 2000. Did get used. So warfarin's a very difficult medicine to use, and I spent a good portion of my career using this. And I don't know if you've ever heard of the term exquisitely painful. That's what they're used to describing treatment with warfarin. So what do we do now? NOAC, DOAC. So these are the four NOACs, DOACs. They're 10A inhibitors, except for Pradaxa, which is direct thrombin inhibitor. These are what's used now for DVTs. Okay, so first of all, you don't need a bridge with Xarelto and Eliquis. So that's why they're the ones that are really used. Before that, you needed to bridge people. Now, theoretically, with Pradaxa and the Doxaban, you have to bridge them. They call it switch therapy, not bridging. So you could directly give somebody this. They have a swollen leg. You could discharge them from the ER, or theoretically from my office. So I see someone with a DVT. We did that last week. Made the diagnosis via ultrasound, sent them home on Eliquis. Didn't go to the ER, got hospitalized. Okay, you don't have to monitor with an INR. And the biggest safety thing, there's less intracranial bleeding. And when you have somebody who's an anticoagulant, you worry about bleeding in general, but you especially worry about intracranial. So how long do you treat, somebody is transient risk factors, just 3 months. Beyond that, and, you know, it's usually extended treatment, you know, depending, now you have to discuss it with the patient. And I'm sure you learned all about patient preferences, all that. A lot of people don't know why physician to make a decision. Theoretically, if the D-dimer stays elevated, or they're a male, they have a higher incidence or recurrence, but those are in God's sense. You have to look at what caused this. And if this was truly spontaneous, you know, there are mild risk factors like a plane flight. You know, you have to think twice about it. If somebody had this post-op, that's a different thing. Often the post-op patients, they're all VTE prophylaxed, you know, in the period, except not obviously cataract surgery or anything like that. Or if you have a woman who's on the pill, no. Okay, but if somebody has idiopathic, and you don't know why, you have to think long-term, extended. Long-term is really up to 6 months. Okay, extended is beyond that. And it's a lot easier now that you don't have warfare, than you know, the money. Other treatments, right? Catheter or percutaneous intervention. Someone's got a really high DVT, iliofemoral iliac. You can think of catheter balloon therapy where you would give living therapy and do a percutaneous intervention. Study came out 3 years ago, finally published, called TRAG, which showed that. So if somebody has a huge small leg, okay, these are people you'll admit place them on IBM and you could evaluate them for this. What about filters? Okay, what?
Too many.
Oh, way too many. And this is, you know, you were still probably in middle school when all this stuff was coming out. When you give a contraindication to anticoagulation. So you have somebody with DVT or PE and they're bleeding, you can't anticoagulate them, that's number one. Failure anticoagulation. So you have a patient comes in, you anticoagulate them with therapeutic and, you know, they still clot. Okay, complication of anticoagulation. You have somebody in pulmonary or heparin or whatever, and they're bleeding. Yep, you gotta put a filter in. Okay, they will decrease PE acutely. Long term, we have a higher incidence of DVT. What you want to do, when you put in a filter, you have to plan to get it out. Okay, you don't want it in there forever. And where a lot of these problems are, people go into the hospital, and they've had the filter replaced. And then they follow up with their doctors in another institution, another hospital system. Nobody did anything about it because they weren't connected. And, you know, theoretically, you could pull them out anytime, but the earlier the better. These filters, you could have a higher incidence of problems. They could migrate, fracture, rupture. You know, I saw one guy, and this was really around 2000. It's a young guy who was under 40 at the time, and he came in, he had a massive, he had a very large PE, he got IVTPA at the time, and sent home with warfarin. I followed her once, and he was lost to follow, but I saw him about 9 months later. This guy came in, his scrotum was about the size of this table. And he clotting, stopped the water, and it just clotted below. And that eventually went down, but you know, you have to,
Yeah.
you have to really, you know, I mean, they're using basically just retrievable filters. And once you put them in, you gotta think when they're gonna be retrieved. And that's it,